Good morning, Dr. Stevens. For rounds today, I've prepared a clinical presentation on a case from our screening colonoscopy clinic. It brilliantly highlights a condition we see almost every single day on the floors, yet we rarely stop to actually deconstruct it mechanically. So we're going to look closely at incidental diverticulosis, and I want to spend some real focused time on the clinical reasoning and the specific anatomical why behind each of our management decisions today.
To structure our understanding, we're going to walk through this in 4 acts. Act 1 is the presentation, Act 2 is the anatomy and pathophysiology, Act 3 covers our assessment and plan, and Act 4 wraps up with complications and clinical pearls.
All right, Act 1, the presentation. Let's start with the human element to anchor this medical deep dive.
We have a 61-year-old man who came into clinic for his first screening colonoscopy. Overall, he feels well, but on careful questioning, he reports a 2-year history of crampy left-sided pain, specifically right there in the left lower quadrant. This discomfort is typically eased by a bowel movement. He struggles with chronic constipation, passing hard stool every 2 to 3 days with a good deal of straining. Now, he completely denies any alarm symptoms. No blood in the stool, no fever, no weight loss. His medical history includes hypertension on lisinopril and bilateral knee osteoarthritis, for which he takes ibuprofen 2 to 3 times weekly. His social history? Well, it's essentially the exact risk factor list for this disease. He smoked half a pack a day for 30 years, works a sedentary desk job, drinks wine most evenings, eats red meat most days with almost 0 fiber, and has a BMI of 31. On exam today, vitals are completely normal, he's afebrile, his abdomen is soft without guarding or rebound, just some mild left lower quadrant fullness. Occult blood is negative, and his hemoglobin is completely normal. And you asked me earlier why an unremarkable exam is exactly what we'd expect here? It's because this is precisely what quiet, uncomplicated diverticular disease looks like before any inflammation sets in.
And this image brilliantly illustrates what we found incidentally on his scope. Numerous, dark, round diverticular orifices just sitting quietly in his sigmoid colon. Notice the surrounding mucosa is completely normal. No inflammation, no pus, no bleeding, no polyps, no masses. Our impression was moderate sigmoid diverticulosis. And remember, by definition, diverticulosis simply means the pouches exist, nothing more.
Moving to Act 2, the pathophysiology deep dive. Now, what's really interesting about this next section is that we are going to build the physical why of this disease from the inside out. Understanding this anatomy isn't just trivia, it literally drives our clinical plan. First, we have to recognize that these are acquired, false diverticula. This means only the mucosa and submucosa herniate, leaving the muscle layer completely behind. This is a stark contrast to a true diverticulum, like a congenital Meckel's, which carries every single layer of the bowel wall with it. In these colonic false diverticula, there is absolutely zero muscle on the wall of the pouch itself. If we build the normal colonic wall from the lumen outward, we have the mucosa, the submucosa carrying the blood vessels, the circular muscle forming a complete ring, and then the outer longitudinal muscle. Notice how that outer longitudinal coat isn't one continuous sheet. It's actually gathered into 3 distinct thickened bands called the tinea coli, covered finally by the serosa. So the crucial structural point here is that blood vessels, the vasa recta, have to cross that circular muscle to feed the inner layers. In doing so, they literally punch 4 rows of structural weakness into the wall. These vessels arise on the mesenteric side, and where they penetrate the muscle, they create tiny gaps. These gaps line up perfectly in 4 distinct rows between the mesenteric tinea and the 2 anti-mesenteric tenei. When pressure rises inside the colon, it drives the inner layers, the mucosa and submucosa, directly through those tiny vascular gaps, while the circular muscle stays behind. Because the muscle doesn't follow, we get this flask-shaped false diverticulum with a very narrow neck that, frankly, drains very poorly. Now let's look at how this builds a dangerous anatomical reality. That critical vasa recta artery doesn't just get pushed aside. Instead, it gets carried right over the dome of the thin pouch. It becomes stretched, thinned out, and exposed. It's separated from the stool and the lumen by nothing more than a frail layer of mucosa. This specific anatomical quirk is exactly why these can bleed so briskly. But where exactly does this herniating pressure come from? Well, the colon's own motility seals the lumen into short, closed compartments called segmentation rings. As the circular muscle keeps contracting against these closed-off spaces, the internal pressure inside that specific chamber climbs steeply. And by applying Laplace's law, we can see exactly why the narrow sigmoid colon takes the absolute brunt of this disease. Laplace's law tells us that wall tension equals pressure times radius. If we rearrange that, pressure equals tension divided by radius.
So for the exact same muscle contraction, a narrower segment of bowel with a smaller radius is going to generate vastly higher intraluminal pressure. The sigmoid is the narrowest part of the colon, turning it into a localized high-pressure zone compared to, say, the wider cecum.
We often debate two competing explanations here. Is it driven by the pressure side, low fiber and hard stool, or by the aging wall? For our patient, I'm committing to the aging colonic wall as the primary driver. Yes, his diet is poor, but as he's aged, elastin deposition in his taeniae caused the colon to concertina and shorten. Simultaneously, collagen cross-linking stiffened the wall, and myoschisis coli thickened that circular muscle, narrowing his lumen even further. This aging pathophysiology essentially overpowers the normal pressure dynamics, creating a rigid, narrow tube. It's the perfect storm to aggressively drive mucosa through those vascular gaps. On to Act 3, assessment, planning, and counseling. Returning to our patient, let's assess how this pathophysiology connects to his specific case and how we should manage him today. Taking a look at his history, it turns out his social background is essentially the exact risk factor checklist for this disease. He hit 9 out of 9 perfectly. He has a low-fiber diet, eats red meat daily, has a chronic constipation with straining, his BMI is 31, he's physically inactive, he's a 30-year smoker, he drinks alcohol daily, uses NSAIDs multiple times a week, and, of course, advancing age. When counseling him, it really helps to quote the numbers to normalize this finding. Prevalence is only about 10% in patients under 40, but it climbs steeply, reaching 50 to 66% in patients over 80. For a 61-year-old, this is incredibly common. We also need to reassure him regarding the scary stuff. Only 5 to 15% of patients will ever bleed, and only 10 to 25% will ever get diverticulitis. Most patients will have neither. Now here is our clinical diagnostic challenge. We have to determine if his 2 years of crampy left lower quadrant pain is SUDD, symptomatic uncomplicated diverticular disease, meaning symptoms caused directly by the pouches without any acute inflammation, or if it's an overlapping condition like irritable bowel syndrome sitting on top of an incidental finding. Both SUD and IBS give cramping, bloating, and altered bowel habits with completely normal inflammatory workups and normal physical exams. Because they coexist so frequently, just seeing pouches on a scope doesn't automatically prove they're the source of his discomfort. And when it comes to dietary counseling, let's use this opportunity to definitively retire a massive medical myth. There is absolutely no evidence that seeds, nuts, or popcorn lodge in the narrow necks of these pouches. The theory sounds totally logical, but a massive prospective cohort study found no increased risk whatsoever. We really need to stop telling our patients to avoid these healthy foods. Our actual, evidence-based plan starts with aggressive reassurance. We must tell him plainly, this is not cancer, it never becomes cancer, these pouches need zero surveillance, and there's no treatment to make them go away. We'll prescribe fiber and fluid for the constipation, though I'll be honest with him that the evidence proving fiber alters the actual long-term course of the disease is limited and mostly observational. We'll refer him for smoking cessation, encourage walking and weight loss, and crucially, Dr. Stevens, to answer your question on what we must change today, we have to swap his ibuprofen for acetaminophen. Because of that stretched exposed artery sitting right on the dome of the pouch, those NSAIDs significantly increase his immediate risk of hemorrhage. We'll wrap up his visit with explicit return precautions. Finally, Act 4, complications and teaching pearls. Let's briefly touch on what happens when things actually go wrong. Remember, the suffix changes everything. Diverticulosis is just the quiet, structural existence of pouches, usually found incidentally with an unremarkable exam, just like our patient today. Diverticulitis, on the other hand, happens when a pouch obstructs and inflames. It is loud, it presents with acute pain that stays, fever, focal tenderness, and a raised white count. But again, the vast majority of people with diverticulosis will never progress to diverticulitis. The other major complication is bleeding. If that stretched vasa recta vessel on the dome ruptures, you get a diverticular hemorrhage. This presents as painless hematochasia, bright red or maroon blood per rectum without any fever or pain. Because it's an arterial bleed, it can be quite a large volume, though it's usually self-limited. And interestingly, while the diverticula themselves are overwhelmingly on the left side, these bleeds come disproportionately from the right colon. And speaking of the right colon, patient geography is a massive pearl here. While Western diverticula are 90% left-sided and localized to the sigmoid, up to 85% of patients of Asian ancestry have right-sided pouches. This is critical for us at the bedside.
Right lower quadrant pain in an Asian patient may very well be diverticular disease, perfectly mimicking appendicitis.
So, I'll leave you with this critical thought to conclude the presentation. Since these false pouches are everywhere in our older populations, how do we ensure we don't just lazily blame them for every stomachache? Anchoring bias on an incidental finding of diverticulosis is exactly how new or changing symptoms get ignored, and tragically, how a subtle colon cancer gets missed. These pouches need to be respected mechanically for sure, but we always have to view them with clinical skepticism when evaluating abdominal pain. Thank you for your time on Rounds today, Dr. Stevens.